Good morning, good afternoon, good evening, everyone, and welcome to the GA Risk Conversation series. I am Adrita Bhattacharya-Craven, and I lead the Health and Aging Research Workstream at the Geneva Association. Let me start by setting the scene for this webinar with the most pressing issue of our time that dominates our everyday lives right now, COVID-19. To date, the world has seen over 217 million infections and about 4.5 million deaths. This is tragic. But there is another severe aftermath of this tragedy that we are not talking about enough. COVID has left many of our health and social care systems exhausted. Our health workforce is tired. Our hospitals are unable to plan their work properly because they're battling with the peaks and troughs of this pandemic. And the vulnerable and the aged are not only at risk from COVID, but from other pre-existing health conditions. If we don't address these issues, not only are we at risk of losing more lives, but we risk destabilizing our very own health and social care systems because of the sustained pressure they will feel from non-communicable diseases, from new diseases such as COVID-19, and from aging-related care. And this is where new care models really come in, a fundamental rethink about how we provide health and care services that is fit for purpose, that is sustainable, and the role health and life insurers as payers for some of these services can play to achieve this. And this webinar is really to talk you through some of the key messages that come up from our recent report that we have published, but we also bring you fresh industry perspective. We have 4 speakers today, including myself. I am delighted to be joined by my co-author, Professor Nicholas Goodwin from the Central Coast Research Institute and the University of Newcastle in Australia. We also have with us Dr. Margaret Mary Wilson from the United Health Group. Welcome, Margaret. And we also have Dr. Christian Ward from the AIA Group. So just some housekeeping. The first part of this webinar is going to be 4 presentations. Each panelist will take about 10 to 12 minutes each to share their perspective with us, following which we will have just over 20 minutes for a Q&A session. Here, we really welcome your engagement. We would love to hear from you, your questions, your comments. You can either raise your hands using the screen and we will unmute you and you can speak directly to us, or you can submit your question using the Q&A function. This webinar is being recorded and this presentation will be shared with participants in due course. So let's begin. Nick, let me start with you. Can you please talk us through what this new care model is about? Why are we talking about it? What is it? What is the evidence for it? And how are people applying it? Over to you, Nick.
Well, thank you very much, Adrita, and it's a great pleasure to be presenting today. As I do so, I'd like to recognise the traditional custodians on the lands which I come meeting here from Australia, which are the Dark and Young people, and to First Nations people everywhere, and we pay our respects to their elders past, present and emerging. New care models are essential for the future sustainability of our healthcare systems. And within this, short 5 minutes, 10 minutes at the beginning, I'm going to lay out a little bit about the evidence and reasoning behind the importance of these new care models. If we go to the next slide, please. I think the need is quite clear when it comes to looking at the increasing demands that we have on our health and care systems, particularly in times of COVID, actually, which you mentioned at the beginning. Certainly we see global patterns, shifting patterns in the disease burden that health systems face, increasing numbers of people living with complex comorbidities and long-term care needs. And indeed, I think it's this complexity of need that is increasing. So as people age, so the numbers of people living with complex comorbidities is also increasing at the same time. What we also see is that the increase is not evenly distributed. So it is to people who have the greatest complexity of need where our healthcare services are least appropriate in terms of meeting them. And as a result of that, what we see is a rise in healthcare costs because we're unable to develop systems that are able to support the management of people's conditions in their own home or in the community, and indeed address some of the preconditions, some of the risk factors that lead to these outcomes. This means that healthcare costs are rising. We develop unsustainably high premiums, high deductible plans, and so on. And there's increasing pressure on the public health systems to be able to respond. So the essence of new care models is moving away from conventional medical-based models, even disease management programs and from the 1990s, to think about new care models which are much more focused upon care coordination, supporting people across care pathways from cradle to grave, continuous care to individuals over the life course, and developing more integrated approaches that focus on empowering people and communities to manage their health with more shared responsibility and accountability between different partners in care for those outcomes. So we're seeing this move, I think, globally in different parts of the world to start thinking about how we can move a lot of our care programs upstream in order to be able to get in front of the issues that we're facing when we're seeing these high increasing costs. Next slide, please. Next slide, please. So the evidence for new care models, I think, is also very strong. So when you look to the Institute for Healthcare Improvement and you see the diagram on the right, one of the things we say a lot in the report is the need for new care models to achieve the triple aim in terms of outcomes in healthcare systems. And that means we're trying to develop models that can simultaneously improve people's care experiences, as well as proving their health outcomes in two ways. Not only health outcomes in how people living healthier, or health outcomes in being able to manage their chronic conditions better, but also health outcomes in terms of the reduction in unnecessary utilization of hospital facilities or long-term care facilities as a result of being more preventative and more able to address their needs. And if you do these two things well, we also are able to see a reduction or at least a comparative reduction in per capita cost. So the hypothesis behind new care models is that we're able to achieve better value in care, triple aim values in terms of care experiences and outcomes at lower cost. And there's actually really good evidence, I think, where when you focus on these models in terms of quality of care and care outcomes and care experiences, but sometimes the way that they are implemented and adopted in different countries may be not as effective because they focus on the structural solutions, they focus on the policies, or they focus on organizational reform, rather than focusing on where the real transformational change happens, which is at the interface between the care professionals and the people themselves. And I'll come on to that in a second. What we also see where care programs are well designed and well implemented, there have been really quite significant sustainable comparative cost reductions that have been demonstrated. So a lot of the managed care approaches that you see in the United States, or approaches that you see in Europe, where they're targeted at some of the higher cost profiles of patients or the elderly population, can save as much as 20 to 25% compared to previous costs or comparative costs in these new care models. That is not an unusual figure. But as I say, it does depend on the effectiveness design of the way that we implement these approaches, and the ability to give them time to develop and mature. Because even in the best systems that we see today have taken 10, 15, even 20 years to get to a situation where they have really quite fundamentally changed the nature of their setup and created a much more sustainable approach as a result. Next slide, please. So there are lots of evidence on how we want to design new care systems. In fact, the building blocks are pretty well known. There are only so many different ways in which you can support people with complex chronic conditions in the home or primary care environment. How we support people with COPD or diabetes or mental health and wellbeing issues, or frailty and independence in the home. The actual methodologies that we use are really quite well known, and there are lots of clinical standards around them. I think possibly what is less known is a recognition of how the system needs to adapt in order to make that happen. So when you look at the core building blocks of effective models, you can see that it's really a system issue, because what we really want to have is engaged and empowered patients who are active in their own care, supported to self-care, supported with their carers to help their loved ones, supported to make shared decision-making with their physicians, and so on. In order to make that happen, we need to be able to have a system that allows professionals to coordinate care and services around the holistic and personal needs in a very active way, to support care transitions out of hospital into home, to support integrated care pathways and care management approaches that enables the experience that people have to be a lot more seamless and also a lot more effective. In order for that to happen, we need the professionals to come together in teams or in networks and to be educated together and trained together and work together, so that there is a positive attitude that professionals can make in order to be able to achieve that care coordination, which leads to the better person-centered care outcomes that you're looking for. And then lying above that, thinking systemically, organizations also need to change. They need to be able to create a platform that allows the professionals to work together. And key strategies might include shared finance or incentive schemes or aligned governance or regulatory changes and that allow for a commonality in the organizational goals of the different parties, so they're focusing in on the ability to deliver new ways of working with better outcomes. And then when you go up to the political level, the system level, we need a scaffold. We need some scaffolding that allows this to happen. And that might be in terms of deregulation or data systems that help the transfer of information in real time, or investments in the workforce or education programs and so on. And sitting alongside that are some of the softer elements of these new care models as well. You know, even where you have the best laid plans in terms of the system that we want to create, people still need to be able to work together effectively. And there are two things here. And one is the extent to which the different partners in care really have the same sort of shared norms and values and capabilities that they really want to work together. And the functional integration to be able to communicate the data. And the big issue here is that we know it's the clinical integration, the care coordination model that matters most. And in order to achieve that, it's actually how people communicate with each other, the behaviors that they exhibit that makes the difference on that ability. So we need to create systems that do that. Next slide, please. So when you look at the new care models within the report that we've provided, what we see is for the insurers is the ability to use that purchasing power in a much more proactive way. And we're really talking about two things. So one is, how can we change the nature in which we pay for services to move beyond an episodic fee-for-service approach to one where we're beginning to pool budgets that allows us to plan and coordinate care and services with partners in a perhaps a more population health-based approach. So we see in the top diagram the move away from single isolated organizations to work in partnership, and away from fee-for-service models to more capitated or lump sum type approaches. And I think what's really important in the report is what we describe in terms of the role of the insurer as really a strategic purchaser, getting much more involved in how services are designed, how the system should be led, how to put in quality markers within the system to hold different providers to account, and collaborating with the broader healthcare ecosystem over time. So these two things, a change in the payment models and a change in the nature of the insurance model towards strategic payer, I think is a really important move. Next slide, please. And the last slide I would say is there are lots of different approaches to this. We have the accountable care organizations in their different forms that we see in the United States, and we also see them in Europe and elsewhere. We even have those that have created fully integrated care systems, where actually the insurance side and the provider side are much more closely knitted together in terms of an organizational form. And we see other forms as well, like direct to provider or direct primary care models that you see in the United States, or consumer directed payments, which are moving away from the traditional kind of insurance-based market to something that is actually much more sort of consumer friendly. What we try to do in the report is have a look at some of the strengths and weaknesses of these different approaches compared to traditional models. And I think what you see when you move towards these more managed care or these new types of models of care, the potential for cost containment and the potential for improving care experiences and outcomes becomes higher. But the quid pro quo to that is the need for the insurers themselves to begin to take on more management capability, to be able to take on more leadership and more organizational capability in order to be able to achieve it. So it's not going to happen without some really quite fundamental changes in the way the insurers are set up. Next slide, please. So I'm going to pass over to Adrita. I think I've done my 12 minutes. So I think the bottom line is, or the key things are, new care models can really work. They require investment and time to support. They do take quite a considerable lot of thought in thinking about the design of the services that we want to create and the scaffolding we want to put around that. There are lots of models that demonstrate that it's possible. So I think what we're trying to demonstrate in the report is that there is a movement here that can allow us to achieve triple aim outcomes, and that we think insurers should seek to move in this direction if they really want to create a positive influence on the sustainability of both the life insurance and health insurance systems moving forward. Adrita, over to you.
Thank you, Nick. Let me take it from here. Nick, thank you very much. You have given us a really good flavor of the first section of the report and really helping us to understand what are we talking about here. So next slide, please. So in addition to the literature review that Nick has just covered, we also had the opportunity to speak to senior executives from 15 large health and life insurance companies, and they have a very wide and diverse footprint, as you can see. We carried out semi-structured interviews with 6 broad themes that you can see outlined on the right-hand side of the slide. Next slide, please. So what did we hear? Firstly, the rationale for implementing new care models. Really, we had 4 broad categories of answer. First one being customer-centric reason for implementing new care models. I will call it NCM just for the sake of time. We heard business-centric reasons, business sustainability reasons for implementing NCMs. We also heard changes in the ecosystem and pressure from the ecosystem being one of the reasons. And definitely the last one, which has come up right at the beginning of our conversation, is the pressures from the demographic and the disease shifts we have seen. This is broadly in line with the literature review, but when we dug a little deeper in this conversation, what we found was the rationale for implementing NCMs among insurers was largely skewed towards the consumer-centric side, to improve customer experience. The others were definitely mentioned in our conversation. Business sustainability followed straight after, but the last 2 appeared less frequently. And in customer experience, you can see some of the buzzwords that we have heard very frequently, influencing well-being, choice, control of our own well-being, quality and perceptions of quality. Those were the most frequently cited words. And just to point out, these rationale were not either or. We were just having fluid conversation, and what we wanted to decode was the frequency with which we heard this to really understand what the pull was. The other notable finding for us is when we spoke to life insurers, we saw a definite pivot towards health. And this is really happening for 2 reasons. One is to mitigate the mortality risk in risk-based products. The other one is to actually enable people to live longer, healthier lives. A lot of life insurance products, in fact, a vast majority of them are savings oriented. They are retirement products, they're annuities products, and they have a long-term savings component associated with them. So it is in the interest of life insurers to also start looking at how they promote active aging, how they promote better health, well-being to keep people in retirement out of very costly institutional care. And you can see a quote here that really captures the essence of this. Next slide, please. In terms of the characteristics of the NCMs, well, there were very many. And so let's focus on the common areas. Firstly, the vast majority of the NCMs that were being implemented by insurers focused on the demand side. And by that, I mean really on the consumer side. They expanded the scale and scope of services, choice of providers. Very few match these with strong supply side and financing reforms. And by that, I mean really looking at engaging with the provider base to find new ways of working or changing their reimbursement models. The other thing we saw is that NCMs tried to tackle a whole range of things, starting from digital triaging to chronic disease wellness and off-the-shelf wellness packages more generally, but very few of these were targeted. They were aimed at the general policy holders. So it's really hard to know as to who benefited from it the most. And thirdly, in terms of the evidence, well, these are early days. The evidence is still emerging, but they certainly point in the right direction. Firstly, there is evidence to suggest it does improve customer access and experience. We see that through more downloads when they're digital products. We see that through more retention, more sales. We also have seen that the dent it's making in costs. So it's certainly helping to reduce costs by reducing hospital admissions or presentation in specialist clinics, etc. In terms of its health outcomes, similar to the literature review, I think we need to allow a bit more time, and this is probably the hardest part of the story. In terms of the market buy-in, how is the market responding to this? And at the outset, it's worth pointing out, stakeholders like government, distributors did not come up so much in the conversation unprompted. Where we focused on was the response from consumers and to a lesser extent, response from providers. On the whole, it was felt that NCMs are responding, or consumers are responding to NCMs very well. But the thing is, it's new, so there is a novelty factor with it. So there were two other associated thoughts. One was inherent in the idea of NCM is the idea of standardization of care to contain cost. And many insurers felt that we needed to balance this standardization approach with the choice agenda, which is often associated with voluntary health and life insurance. But other insurers also countered this thought by saying that, but look, if we can really articulate the value of the NCMs, then today's consumers are more willing to make those trade-offs. In terms of providers, the response is more mixed. On the one hand, they definitely see NCMs as being able to generate a lot of traffic, so more people. But in terms of where they really sit in that constellation of NCM and what is that grand scheme that they are trying to achieve, that objective is sometimes not clear to them. And this again underscores the point that Nick made during the presentation, is that insurers really need to start looking at those organizational structures, and start familiarizing them with the supply side, the provider landscape, and also rethink the way they work with third-party administrator models in the future. Next slide, please. In terms of new opportunities posed by NCM, we had 4 big areas. NCMs generate a lot of data, and that data could be used to finesse existing products. NCMs also needed new competencies, and once these were established, there was an opportunity to package them and sell them as key tools, say for population health management or for off-the-shelf wellness products. It also enabled insurers to move to a slightly less safe segment of the population. And I'll give you a short example. Traditionally or historically, life insurers will shy away from providing coverage to a diabetic or a pre-diabetic person. But now they can, because with NCMs, they have the tool to manage that risk. And finally, it also enables insurers to diversify from exclusively risk-based products, so health plans and life policies, to more service-oriented products. Our own research has shown that consumers are quite indifferent towards the idea of insurance, but what they do care about is service delivery. And NCM really provides the platform for insurers to embrace service delivery and manage it in a way that we probably have not seen in the past. Having said that, there were a few areas of concern. One is articulating the value proposition to consumers. It's a very noisy market out there. Secondly, there is this reliance of third-party administrator model, which means that insurers are sometimes working in the dark about what is really going on a daily basis with that interface with providers and consumers. Understanding return on the investment is still a bit of a struggle right at the outset. And adverse selection. So there were some thoughts saying that, look, if some of these products are targeting dementia or diabetes, are we at risk of drawing more of those risks in our pool? And in which case, it might destabilize the product itself. And finally, the short-termism. It is people are worried that if you invest now and the person you are investing in now will move on to another insurer. But it was also countered by the idea this is the very reason for doing NCM, is to enable that consumer engagement, and otherwise the idea of this market churn just reinforces itself. Effect on the value chain. The marketing and distribution were the most common area that was highlighted. And you can imagine why, because of the digitalization of the whole thing, we are able to reach more people. Other parts of the value chain, such as underwriting or pricing, were less frequently highlighted. This presents two glaring gaps. One is it's fine to be so enthusiastic about the digitalization of marketing and distribution. What do we do with this vast intermediary-led channel? This is one area. How do we train them up? And the lack of focus on these other institutional structures, such as underwriting and pricing, really it's not happening enough in the way we would like it to happen. Considerations for scalability, I think the report and the slide says it all, but basically we're talking about the regulatory environment, particularly around health licenses and data protection and market reform. Data, how do we use data when we actually have? We need that capacity. Leadership, again, that comes up in Nick's presentation, looking at how we enable risk-taking in a company where the leader promotes risk and encourages risk to try new things out and allowing longer time horizons to learn from it. And again, it comes up on this concurrent focus on the supply side. So then we go to our final slide. Next slide, please. So based on these findings, we make 3 recommendations. One is to move beyond this simplistic notion of choice, and consumer needs will be central to the way we design and implement NCMs. But if we want to really deliver on the promise of NCM, we need to start talking to other stakeholders, including governments, distributors, providers, and internally within companies to have that support. Number 2, we move away from paying claims to becoming that's very strategic orchestrator that Nick pointed out. We need to know where our risks are coming from. We need to then design the NCMs based on that and adopt new innovative payment models. And then we also need to create an ecosystem over time to allow that healthy interplay between demand and supply. And finally, if life and health insurers are really serious about caring or looking after the entire care continuum, from prevention to case management and old age, they need to start talking to each other. At the moment, life insurance products are being sold with a bit of wellness, with very little idea of what happens when the person falls ill. Similarly, we are selling health insurance products, knowing very little about how the person will be supported if they fall ill, be that carer support or retirement planning or income support. So we need to start at least envisioning what this cradle to grave system might look like, and then looking at practical touch points, such as could we do a marketing plan? What would that look like? Or what are the strategic data touch points? I will stop there and now go to Margaret, if I may. Margaret, that was our report. It talked about the academic evidence and what we heard from some of the largest insurers, including yourself. But I would love to hear your perspective on this. And also, I go back to our first initial conversation that I had with you when you made this very famous quote, which has stuck in my brain since. It is, there is this idea that there's a provider and there is a payer, and never the twain shall meet, won't work. So what is it that United is trying to do with the supply side of the market? Thank you, Margaret. Over to you now.
Thank you so much, Adrita. It's a pleasure to see you again, and thank you so much for having me. I'd like to start off, in an attempt to answer your question. Could we go to the next slide, please? And the next slide, please. Fantastic. I'd like to start off in an attempt to answer your question by introducing you to Joan. Now, Joan is a hypothetical patient who has detected a lump in her breast. And what I'd like to do is walk you through a journey that many patients experience to show some of the key challenges and pain points in many of our healthcare systems today. I'll reference some of the underlying causes and how we at United Health Group are driving towards a modern, simple, high-performance healthcare system that will improve experiences for patients, providers, and payers with better outcomes and lower overall cost for everyone. Now, I will not describe every step of Joan's experience in this first slide as she tries to use her healthcare system, but I think a glance at the slide makes the point. Joan's journey is complex and it's confusing. There are many challenges in her experience that typify experiences within the healthcare system. So care and the way it's delivered and managed is not always proactive. If you use the example of Joan, her clinical information is pretty disconnected. It's difficult to access and it's difficult to use in a timely fashion. There are multiple steps in her journey as she attempts to seek care that often lead to delay. And if you think of Joan in the middle of all this, you can imagine her level of anxiety and worry. And as you look at her journey, there are multiple approval points that bounce back and forth, multiple points of alignment that are required between payers and providers, rendering her journey very unclear and very complex. Now, when all these experiences are packaged in one slide, it may seem like an over-dramatization. But I'm sure if we all stop to think about it, we can all point to similar examples from our own personal experiences. Next slide, please. Currently, I think we all recognize that providers and payers are focused generally on delivering quality care and outcomes for people and for patients. The challenge is that the historical approach has been grounded in two different economic perspectives. So historically, providers have been concerned with predictable revenue streams, right? And claims payment. While historically, payers have been concerned with claims and payment accuracy. And ultimately what happened is that this model was distilled down to an unfortunately simple and yet somewhat false formula that provider revenue equals payer expense. And what happened historically is that created fertile ground for friction in the relationship between providers and payers. What we see emerging today is currently the reality, even though it might not make mathematical sense, the reality is that the real formula is that inefficiencies in the system create expense for everyone and threaten healthcare sustainability. If you think about it, both parties hold critical keys to solving the same puzzle. So the providers generally have the most current clinical view and data for a patient at the time of care. However, they lack full context in many cases, right, of the entire clinical picture, depending on the point at which the patient engages the healthcare system. The providers also often lack a full view of the payment policies, right? So they're not really sure, what is covered and what is not. And because they lack the full picture, they're also not clear as to what are the truly holistic next best actions for the patient. So the actions that the provider takes may or may not align with what the payer is willing to authorize because they're two different sets of information that are disconnected often. The payers hold the keys to the payment policies and how specific treatment and claims will be approved or denied. And often the payers don't have complete and up-to-date clinical data for the patient to understand the full context of the provider's request. In the middle of this sits the patient, wondering what he or she should do next, not clear as to how it costs, and with the added emotional dimension associated with anxiety and fear about one's own health or that of a loved one. So multiple points of friction, right? A cycle of response, feedback, response, asking for more. And it's an iterative cycle, everyone working through multiple cycles to get it right. And what that generates within the system is a huge amount of waste and distraction from the patient. Within the healthcare system, it's estimated that about $275 billion, right, is the amount of this addressable administrative waste within the system. And the patient is often left very confused. Sharing a quick example, a colleague of mine, not a clinician, had a son who was trying to, figure out and, what the cancer treatment was for his father-in-law. He called his father-in-law to see how it was going, and his father-in-law said he was required to furnish the correct DRG. And the patient had no clue what that was. No patient in seeking care should ever have to know what a DRG is. That's strictly an insurance and medical term, but this is just an example of how complex a system can get. Much room for improvement. Next slide, please. So multiple challenges within the system. There are really 4 key challenges. The first is the difficulty with bringing claims and clinical data together at the right time to support informed decision-making. The second is the disconnected flow of clinical and claims data and the different timing. This creates a lot of rework, increases the risk of denials, increases the risk of provider abrasion by the payer. The third is often the fact that manual intervention is required to fix some of these challenges. And typically, it's focused on fixing the challenge related to a specific episode of care that does not carry through across the patient's journey, with the risk of having to fix that at yet another point in time. Right? So if you think about the fact that there are billions of transactions that flow through the system, you can see how this drives inefficiency. And fourth is the financial experience. The financial experience for payers and providers is complex and manual in many cases, and the patient's financial experience is often confusing because it doesn't resemble how they interact in other financial experiences in their lives. Next slide, please. So what we see is that we've often, there've often been one-sided solutions, with the payer trying to optimize the experience on their end and the provider trying to optimize the experience on their end. But this further increases the imbalance, right? And can actually increase the tension. At United Health Group, we recognize that we're in the unique position of serving both sides through, and so we can broker solutions, right? Benefits and care delivery, right, that are cohesive and reduce friction and waste within the system, and also build trust. One example of this is our Practice Assist program. And this is a technology-enabled service model. Here's how it works. We leverage advanced analytics and a sophisticated workflow to help the provider complete comprehensive pre-visit planning and have insights already available when the patient visits. And this continues also post-office. So Practice Assist connects a provider support team, which is sponsored by the payers, to work with the providers. And together, this team from both care delivery and benefits are able to derive actionable insights to identify gaps in the patient's care and ensure the patient gets important screenings, prescriptions are relevant, and that the necessary care following the appointment is in place. Another way that we're addressing this is by driving real-time information to the point of care so that the provider is able to make more informed and clinically advanced decisions. Point of care assist is a technology that we leverage, which is able to pull through claims data into the EMR so the provider can rapidly assess the next best action for the patient and identify gaps in care. We're also working to leverage technology to enable sharing of payers' payment policies upstream into the provider's claims creation workflow so that prior to submitting a prior authorization request, they have access to the clinical information required to ensure that appropriate requests are put in. Bringing all those solutions together, right, will ultimately result in a network that's more transparent. Next slide, please. So Joan's ideal healthcare journey benefits everyone. It results in a journey that's simple, transformative, decreases the administrative burden within her journey. Providers are able to share key clinical information with the payer. The payer is able to openly share payment policies with the provider. And so that together, it simplifies the system and really pulls out abrasion, drives outcomes, and decreases cost. Next slide, please. Everyone wins with increased transparency within a network. The payer-provider relationship becomes more open and collaborative. Increased trust is built up. It's more standardized. We're able to leverage automated solutions to reduce waste. That improves outcomes and decreases cost for everyone. And most importantly, the patient's journey is simple and truly drives towards a much more person-centric model. Much easier to understand. Patient understands the care, understands the expected outcomes, and has transparency into the next steps and what this all will cost for the patient. So I'll stop at this point, Adrita. Thank you for letting me share a few thoughts.
Thank you, Margaret. You have really spelled out this orchestration idea about what the role of a pair could be in order to reduce that friction and just sort of make this all very seamless in terms of its interplay between the pair and the user. Let me move to Christian. So Christian, we had the perspective of a health insurer put forward to us. What I would love to hear are two things. One is your life insurance perspective, and why did you embark on this journey? And also knowing where you operate, which is a lot of it is in Asia, though not exclusively so. You know, these markets are very, very diverse. So give us a sense of how this is going. So over to you, Christian.
Thanks, Adrita. And I think really informative views from both Nicholas and Margaret in terms of mature market settings, and what I'll try to do this morning, wherever you are in the world, is just give you a view around where you've got the spectrum of markets that we operate in, from emerging through to mature markets across Asia Pacific, how we've applied new care models in the journey that we're on. If you could just move forward a slide for me, and just the next slide. Thank you. So really just to understand a little bit of background and the footprint we have across 18 markets across Asia Pacific, really just 3 points I wanted to call out. One, with 36 million individual policy holders with leading life and health insurance positions across a number of our markets, with 16 million group scheme members, we're one of the leading employee benefit providers, which again puts us in a unique position. And then being a life insurer with significant premium agency and professional agency, tight agency workforce, it really gives us a position with distribution to engage not only in the sale of insurance, but actually engage with individuals in and around how they will consume healthcare services. And that enables us again in a unique way, which I'll go through over the coming slides. But we have a clear brand purpose in around healthier, longer, better lives. And as Adrita mentioned earlier, uniquely from a life insurance perspective, that ability to ensure people lead healthier, longer lives. It very much addresses that shared value construct in and around the customer inherently wins through that. And as an insurer, it's not only about indemnity risk, but it's also life and mortality insurance risk. There's an inherent win-win there for all parties. If we just move forward a slide. So really the attempt and where the journey that we've carried through is in our health and wellness strategy, and is in this presentation of an ecosystem of services. And again, with previous speakers, but the predict, prevent, diagnose, treat, recover journey that customers walk through. And just a few of the pillars, just to draw out some of the pieces across our region. Vitality, which we have across the Asia region in collaboration with Discovery, very much around a shared value and behaviour change program that rewards and incentivizes individuals around their wellness. And we get a significant footprint in terms of the data, not only in terms of engagement, but amassing longitudinal levels in and around health outcome benefits. Telemedicine, again, we have a full spectrum across our markets in terms of the way different markets have started to now engage quite significantly with alternative and virtual aspects of healthcare. Some of our markets pre-COVID had very low levels of engagement around telemedicine, but we've really seen that pick up, as you can imagine, as we've all gone through periods of lockdown and inability to access care. Interestingly, that's as much in and around physical health as it is mental. And so we're seeing significant changes and evolutions of consumer behavior. The other piece, and again, just touching on, and I think it's an interesting parallel to Margaret's view around the depth, particularly in the US market, around that payer-partner interaction. Our ability, again, in the context of Asia, around case management, which is very much enabling both diagnosis, treatment plan, and ensuring high customer satisfaction rate. But it's that ability, again, as a life and health insurer in markets that are still evolving, both in data as well as maturity of provider systems, that we have to be quite proactive, sometimes on the periphery to those customer journeys, to try and ensure improved health outcomes for our members. But tying it back to the NCM triple aim that Nicholas walked us through, aiming very much for a better customer experience and how we engage with members on digital journeys. A full view around both cost effectiveness as well as scalability, as we take a regional view as well as local. And as I've alluded to, in our journey to being a strategic payer and partner to our customers, a real focus on healthier, longer, better lives and measuring improved health outcomes. If we just move forward a slide, please. This echoes back in terms of some of the primary content again in the earlier discussions, but again, the 5-5-70 approach, and we face this globally, and obviously it evolves market to market, but really seeing then the shared value construct, whereby if we're able to incentivize people into improved healthy behaviors, they win not only in their healthier behavior, but in terms of the lifestyle rewards that we're able to give to them. We as an insurer obviously see improved morbidity and mortality benefits, and then back into a societal benefit. And this ties in neatly, again, as I said earlier, in terms of having a professional agency, tied distribution networks across our markets. The ability of an agent, not only at the point of sale, to explain what an insurance product is, but then in a number of our markets, our agents are integrally involved at the point of claim, and to highlight where we've launched new health services, that the members are aware that these services exist, and are able to utilize that in their own benefit in terms of healthier and improved health outcomes. And the construct is very much around know your health, improve your health, and enjoy the rewards. And you can leave it and take it a lens is this purely just a behavior change program in and around wellness? But we see this as very much the vehicle of this initial engagement with members as we then move through the acuity of their risk, and along both their life journeys as well as their health and wellness journeys. But it's all about having that initial engagement and relevance to individual customers. That means that we're able then to deploy deeper new care models off the basis of a trusted relationship through our wellness platform. If you could just move through a slide for me. And so how does that manifest? So what we really look to do is ensure that if we're thinking about customer journeys that begin with relevance to all members, but also the ability to think about a journey whereby you can engage in high frequency and not be episodic, but be relevant on a daily basis, and pull people through these journeys based on their risk need, and the relevance that we can then play through that. So if I take a traditional pyramid, as you can see, around healthy, at risk, chronic, and complex conditions, if I use the example here of what we've launched across several markets, so real-time AI food scoring. So again, it's a simple tool, the ability to take a photo of your meal and understand really what does that mean in terms of both health status, nutritional status, relevant to any member that we cover, but then the ability of that to be just the beginning of a journey to a nutrition assessment, to a weight loss intervention if you're then at risk, and obviously pre-diabetic for a number of people, and then all the way through to more condition management programs such as diabetes management that we've touched on previously in the webinars. But again, it's all then linked in a consistent digital journey such that we're maximizing the ability of people to engage with us at the point of need. And that pivot, and obviously in the pandemic that we're all living through currently, but with that always ensuring that there's relevance to the programs that we're offering digitally. And obviously some of the examples I'm giving below there in terms of making sure that different programs that we offer that you can do at home, obviously the importance of vaccination and how we can then ensure that some of our programs reward people for undertaking vaccinations. But it's more than being agile in the construct and understanding that the dynamics that we have with consumers in and around their health and wellness journeys, we need to continue to evolve our propositions to remain relevant and be able to deploy against new care models. And just to the final slide, please. And how does that manifest then as an insurer? So in terms of on the individual side, really bringing products to market, such as the one on the left, which is one of our Malaysia product launches around their total health solutions, but really looking to make sure that if you're taking healthy behavior options, how do we reward you in terms of, as is illustrated here, in terms of a health wallet construct that you can then spend that money back in terms of other services that enable whatever it is that your life stage and requirements are through both either recovery, mental health benefits, for example. And then at the same time, that same product is integrated with our wellness proposition. So as you then engage with our wellness program, not only from a claims perspective, but actually through the tiers of engagement with the wellness program, you earn further uplifts into that health wallet construct. So it really is integrating the different strategic payer and payer to partner ecosystem services at both the front end of wellness all the way through to health-seeking behavior. The flip to that, and as I said earlier, with a leading footprint across employee benefits, how do we work with employers around population health? And mental wellness has been a big feature for us, but really understanding how we can work with employers to ensure that the workplace and how they engage around health information and awareness through to then the digital tools we give to employees so they can engage with their own risk, and very much a process around learn, act and chat and make that as engaging as possible. And then bringing it all the way through, not only from wellness, but as you can see at the bottom there, in terms of making sure employee benefit coverage and psychiatric and psychologist networks are available to people at that point of escalated need. So really focusing around how we can bring holistic propositions that follow people's journeys in terms of both risk and escalation of risk, but also high engagement touch points, making it as relevant as we can to individuals and then moving them through personalized journeys. So I think just the last slide, if you want to move to, I think just trying to sum up there that in the context of Asia, with emerging through to mature market settings, we really need to focus on how we can scale ourselves as appropriately as possible digitally with tools that really do give high frequency and daily engagement features, and then tailor that as quickly as we can around risk levels, so we can ensure that we can be both scalable, cost effective, and drive healthier, longer, better lives for our customers. I'll pass it back through to you at that point, Adrita.
Christian, thank you very much for that. It's fascinating to hear about what scalability looks like in Asia, and therefore the emphasis on the digital interface. And it's interesting to see, the how you've combined behavioral science and incentives to create a platform. And then now is the time to build on it, and you're on that journey. And we would love to follow over the coming years as to how you build this platform to achieve the triple aim and to build on it with new care models going forward. So now is the time for our more interactive session, and we really welcome you to engage with us. You can do it in two ways. You can either submit your question using the Q&A function on the screen, or you can simply raise your hand and we can unmute you and you can speak directly to us. But perhaps while we wait for the questions to come through, I might just start off the session and do a little warm up. Nick, can I come to you? You touched on the importance of the design elements and the implementation approaches of NCM and how that requires good management, good leadership. Can you point to any sort of critical factors from that slide that you presented to us as to what is really, really necessary to support the adoption of NCMs?
Yeah, so what you see internationally, a very varied picture, actually. So in terms of the ability of insurers or other providers to develop these new care models, and I think the issue of leadership and management and the softer skills that are required to bring care professionals together or to engage with consumers effectively are sometimes overlooked. We create the design that we want in terms of the system, or in terms of our product to promote health and wellness, or in terms of our care coordination models. But actually, when it comes to the implementation, we kind of let ourselves down. And I think what's needed, I think, are three things. And I'm drawing on some of the experience in the Netherlands when the healthcare insurers there began to support the development of new care models in primary care, particularly in chronic disease management. And there was a great variation in their ability to achieve triple aim outcomes and achieve benefits for people. And it really came down to three things. Firstly, was there enough in terms of pulling at the hearts and minds of the different care professionals and organizations to get involved? Did they feel as though they were actually making a difference to their patients? And was it something that they wanted to be a part of? Was it reputationally sound? And that needed bringing people together for that purpose, to create a kind of guiding coalition and momentum to bring people to the table. But it was more than that. There was actually the need for mutual gain. And quite often, a lot of these projects fall down because the different professionals or providers in the system feel that some people are gaining and some people are losing. So when you're leading this kind of system where you're trying to mobilize a provider network, or you're trying to engage with different partners, there's a real need to understand, what the benefits realization is going to be for each party. And some of the problems with these approaches is that it's not equally shared, some of the benefits. So there's a role for leadership in management in trying to work through that process. And because these approaches are never, you never really get a guiding coalition of the willing when you bring people together for this purpose. They tend to be more sort of vipers' nests of vested interests. So you need to have good leadership and management to kind of steward the process and to be able to bring people to the table in a very effective way. So I think the leadership and management elements of it are really important. And it speaks both to what Margaret was saying in creating the technical efficiencies by being able to operate much more effectively as a system, but also to the ability to be able to create really interesting new products to bring to market.
Thank you, Nick. We actually have a raised hand, and we have a raised hand from Gisela Plasman. Events team, Casey, would you be able to unmute Gisela? And Gisela, welcome. Can we unmute Gisela, please? Gisela, I think you may be on mute. Oh, I think we may have lost Gisela. Okay, let's move on to quite a number of questions being put through to us. So while we wait for Gisela, let's focus on a question that has been put forward to Nick. I beg your pardon, but to Christian. So This is a question from Joydeep Roy. Christian, the question is, while running your activities for a few years now, have you been able to actuarially link the health activities to actual quantifiable decrease in mortality or morbidity? And have regulators allowed you to create specialized products based on these measures? And Joydeep writes, as a global leader of health insurance in PwC.
So thankfully, it's a good question because again, that's asked in a number of different contexts. So thankfully, as I mentioned earlier, in terms of the AI Vitality program, we were able to draw on the longitudinal data from Discovery Group have had the program in place for over a decade. So a lot of all the products that are taken to market are taken to market with a shared value construct, and underpinning that from an actuarial perspective is the improvements in morbidity and mortality, such that the part of the framework and the products have an inherent discount that then you're able to maintain as you engage with the program year on year. So the entire piece is actuarial and science-backed in terms of the ability to make those pricing components come to life year on year for our customers. And that's part of, as well as the lifestyle rewards and other reward features of the program, that year-on-year discount approach as you continue to engage with the program is fundamental to that. So in the Asia context, yes, multiple year and longitudinal basis, and we see a number of benefits as we look at our own data, as well as working with reinsurers who also are able to reinsure against those actuarial longitudinal data points. So it's quite robust and has enabled us to continue to innovate in this space.
Thank you, Joydeep, for the question, and thank you for the answer, Christian. We have another question from Vineet. Is there a regulatory perspective, a case or outline, or integrating healthcare gadgets and accumulating points to pay for health insurance premiums, or rewarding them in the form of claim or other incentives? I think we have two insurance colleagues here who can probably shed quite a lot of light on that. So perhaps I should start with Margaret and then move to Christian, who I know also uses these sort of incentive schemes. Margaret, I wondered if you have used incentive schemes or people's good behavior as points, so they are able to generate savings for them through premiums and claims. Oh, Margaret, you may be on mute.
Thank you, Adrita. I was on mute. My apologies. I think at United Health Group, what we find successful is really the model that calls for aligned incentives, bringing the payer, the provider, and the person in the center of care around the same goal, which is good outcomes for care. I think that focusing on that, because I'm trying to ensure that I understand the full context of the question. I think it's about aligning incentives. I think focusing on that is really, really the key to that. We have found, for example, to date, we have about, when we look at our US business, for example, we have about 20 million people participating in some form of value-based arrangement with Optum, which is our care delivery business, and United Healthcare, which is our benefits business. And when we look within Optum, which is our care delivery business, we're working really quickly to accelerate our risk transfer between the benefits and the care delivery with full capitation arrangements. So aligning incentives, I think, is key. I think the question also speaks to rewarding good behavior. And within the industry, there are definitely discussions around that. I think a fairly straightforward one is the impact of smoking on premiums, where people who smoke pay higher premiums. And that works to a certain extent. But I think that as we move forward, the key here is ensuring that the person at the center of care understands the full value proposition that both the provider and the payer bring to the table. And then we're all working together in one direction. Thank you, Adrita.
Thank you, Margaret. I will also go to Christian because I suspect you will have something to say around consumer incentives and rewarding them for good health behaviors. So I wondered what the AIA experience in Asia has been on that.
So thanks, Jim. And I think, and part of that question had the regulatory component to it. So yes, in the context of emerging all the way through to mature market settings, every regulator in every market either takes a different view or doesn't have a view because it's first to market. So we, with every market launch, engage closely with the local regulator. Again, back to similar principles that we were just talking about in the presentation around shared value. What is the program? How does that then incentivize members for long-term benefit? So we go through that cycle in every new market launch because every regulator wants to ensure that what they're allowing us to do as an insurer is actually in the benefit of the member in terms of sustainability as well as outcomes. Part of the question also touched on incentives and medical devices. So yes, in terms of, again, market to market, what does that look like? How are those incentives in a number of our markets? We have, again, because of regulatory reasons, service companies that aren't part of the financial services entity because a rewards construct needs to come through a different entity because of regulations on from a financial services perspective. That's different market to market, and we ensure that what we do is we construct a program that obviously is regulatory compliant but able to deliver the outcomes that we're looking for in terms of the program and the engagement component, all the way through to markets such as Australia, where we've launched sort of Apple Watch benefits, whereby again you engage for a 2-year period, and as long as you continue to engage in the program, you get that added incentive of the device, and in that case, an Apple Watch as an example, is paid off through that process. So you can make the incentives and the device, because in that instance, it's both a lifestyle device, obviously, as well as the device that you're engaging with in terms of your biometrics. You can make it a real win-win for consumers to have sustained engagement over a multi-year basis. So it really does give quite a flexible way you can pivot through that sort of ongoing engagement with individuals.
Thank you very much, Christian. I will move on to the next question that has been submitted to us. But before I do, can I just remind our audience, please don't be shy. Please feel free to raise your hands. You don't just have to submit questions on the screen, although they are great to have, and we have quite a few as from what I can see. So let me go to the next question. And Nick, this one is for you. So how do you think the current care models are effective for senior citizens, so for the elderly population? From the global landscape, what do you see happening in this space?
Well, they're incredibly fragmented and difficult to access. So particularly for older people with frailty, complex comorbidities, this can be a very alienating landscape. So if you went to, say, a couple in their 80s, and the wife is the carer, and the man has dementia and Alzheimer's for a number of different years, and you began to talk to them about their experiences, they're probably juggling 15 to 16 different touch points of people trying to support them to stay healthy and well. And none of these people are talking to each other very well. The data doesn't flow between them very well, and they're feeling extremely stressed in terms of the carer, in terms of getting the care and support that they need. So I think the way that we don't coordinate care effectively around older people's needs in particular, I think is a real issue. And I think there are huge benefits to be made by focusing on senior citizens, because we know that a lot of these new care models, a lot of these integrated care models, can have a really significant benefit both to them in terms of managing their conditions in the context of how they're living their lives, but also to the system. So when you look at things like dementia care or end-of-life care or people supporting care when they're maybe lonely or isolated within their own homes. There are really quite a significant number of different approaches that you can make, from improving multidisciplinary care in the home environment, intermediate care to support better care transitions from hospital to home and keep people as independent as possible, health and social care schemes. There are just so many of these different aspects, and the more that we can provide new care models that help to coordinate the care and services for these individuals or couples, you actually get significant benefits through reducing the propensity for individuals to end up at risk of a fall, or going into hospital when they don't really need to be there, or falling into the need for long-term institutional care, or not being able to manage their medications appropriately. And actually, a lot of the interventions are relatively simple. It might be as simple as a primary care team with a social worker, a nurse, and a GP, and somebody else actually providing care and support on a regular basis to people. And it can have a really significant impact. And so we look around the world, some of these new care models are fantastically effective when it comes to the older age group. And indeed, there are just so many different examples of what can be achieved. And it's smart for everybody, because it hits all of those triple aim aspects. There's just so many examples that you could point to internationally for this area, and yet we don't do it. And it's not clear why, because there are significant benefits to health systems and to consumers alike.
Thank you, Nick. We have another question coming from Anthony Cabrelli. The question is, to make new care models really work, the investment has to be made in, to make sure the providers of care are particularly doctors have confidence. I think I'm going to take this to Margaret. Margaret, in your work in many LATAM countries, you have particularly put in a lot of work in terms of making that a bit more of a seamless journey, both in terms of reducing the friction that we tend to have with organizing provision in a very large fragmented marketplace. How do you start off that? And also over time, how you reduce that friction and make it more of a seamless journey from payer, provider to consumer. And I just wondered if you can give us a couple of global examples of where you have done this.
Absolutely, Adrita, thank you. And Anthony's question is really spot on. Prior to my current role, I was the Chief Medical Officer for United Healthcare Global. And it did pan out. One of the, I think one example of where this was successful was our work in Brazil, where we have both the benefit business and we also have the care delivery business and some integration between them. And it was clear that once we were able to advance an evidence-based model that called for the payer to engage the provider directly, right, around guidelines that would truly decrease costs and improve outcomes, and provided insights for the provider into risk and cost implications, we were able to actually ensure that there was a decrease, that only patients who should be admitted were admitted. And we were also able to support efficient transitional care when they were discharged to ensure that they were not readmitted and limit the stay in hospital appropriately. And bringing the provider closer to the payer in that nexus, we were able to show over a period of 12 months, a 27% reduction in inappropriate admissions to acute care hospitals in Brazil, a 17% reduction in inappropriate admissions to the intensive care unit, and there was a slight decrease in mortality, which indicated improved outcomes. We had a similar experience in Chile during the COVID pandemic. And this speaks to the question about the elderly, right? Where there were challenges with accessing the healthcare system. And what happened in that case is that the payer worked with the provider to develop pre-packaged products around rehabilitation, home nursing care, oxygen and physical therapy requirements, They came to an understanding around the cost of those products, the expected outcomes. And so they were able to rapidly stand up, payer and provider working together, a home clinic team to support vulnerable patients during the pandemic. So, Anthony's completely correct. I think that if there continues to be a disconnect between the providers and the payer, it will significantly hold back modernization. Thank you, Adrita.
Thank you very much. We just have a minute and we do have another raised hand from Helena Karaukis. Helena, I'm not sure we will have time to accommodate your question, but please feel free to pass them on to us and we will pass them on to the panelists and perhaps we can do this offline. But I wanted to take this opportunity now that we have come to the end of the webinar to thank all my panelists, Margaret, Nick and Christian, for your time to make this happen. I'm also very grateful to my events team who have put in a lot of hard work to make this all work very seamlessly. And thank you again for the great discussion. I think we have started this journey. I think from an insurer angle, there is still a lot that needs to happen, but we are right on the track. We are at least discussing the right things. And I'm looking forward to continuing this discussion with you all in the community to see how we can develop this over time. But thank you again for joining us. And we hope to see you soon. There will be a little pop-up survey at the end of this call when you sign off. And we'll be very, very grateful if you can leave your comments with us. Thank you again and take care. Bye-bye.
Thank you, Adrita.
Thank you.
Thank you, Adrita. Bye.